Good evening to my colleagues in India and America and all parts of the world. Hello. Thank you, Dr. Dixon, for the opportunity to be involved in this webinar. I think Doctor has given a good explanation as to my career. I'm just going to see if I can change the slide. Oh, sorry, there we go. Yes. So I think Dr. Dixon has given a good explanation as to my career. So I'll leave those points on the screen. It was quite interesting, the image he'd sent, that the icon of me hiking looked like a guy with an oxygen cylinder on his back, which I thought was quite funny because I've actually had to retire from veterinary practice as I have a lung condition. So it looked to me like a man hiking with an oxygen cylinder, which is about where I'm at the moment. So that was quite amusing. I'm also pleased that I'm doing the 96th webinar. I wish I was doing the 100th webinar because I might get a prize. But yeah, I'm still happy to be doing the 96th. So thank you for joining me, and we'll get off now and we'll start talking about eye cancer, and hopefully my photos I've collected and the presentation will help you to gain some further insight. Okay, so here is a typical squamous cell carcinoma on a third eyelid, and we saw hundreds of these every year in Australia. Squamous cell carcinoma is the most common eye cancer, and it's also the most common tumour of cattle. It really would be 90% of neoplastic disease that we see in cattle. We see them all parts of the eye. The third eyelid, or the nictitans membrane, is the most prevalent, followed by the eyelids, the skin of the eyelids, then the eyeball, and then sometimes on the conjunctiva around the eyeball we see some as well. The other location is on the vulva. So pregnancy testing Frisian cows, we'd often find a thickening around the vulva, and that would be important to pick that up early for treatment or decisions to be made. The disease in West Australia has a very significant economic effect and also a welfare effect as well. Many cows do not finish their production life because of eye cancers, so it's a very important thing for vets to be well aware of. But the disease can be well managed with a good program, and that's our job as vets, to really make sure that we educate farmers and that we also respond very promptly and with the right treatment when we find an eye cancer. So here's a Montbéliard, is a French breed of cow. It's a lovely heifer, probably pumps out lots and lots of milk, but she's the perfect candidate for a third eyelid cancer. She has, let's go over my chat box. Yes, she has very, very beautiful, soft pink skin like me around her eyes. So she is a time bomb for developing severe eye cancers. Okay, so the eye cancers basically occur because of solar radiation. The Frisian breed originated in France and parts of Germany, and they just don't get the high levels of eye cancers that we get in Australia and other places where there's higher levels of solar radiation. The breed predilection is based upon the lack of pigmentation around the eye. And there is other factors which are very small factors, such as nutrition, the production system the animal's in, and there may be some viral involvement, but these areas are fairly insignificant compared to the breed of the animal and the pigmentation around the eye. Another thing to bear in mind is that some Frisians will have black or even brown or red areas around the eyes. That's great for protection of the eyelid skin from cancers, but it doesn't offer any protection for the globe, the eyeball, the third eyelid, or the conjunctiva. So that isn't a solution in itself, just having a black face on a Frisian cow or a crossbred. Okay, so we'll have a look at the breeds. We mentioned the Frisian, the Holstein Frisian. The Montbéliard, very susceptible. Any cross of these breeds will increase the risk of eye cancers significantly. So if we have an F1 that's half Frisian, then half a less susceptible breed, it's going to be 50% prevalence. And then as we breed the Frisian out of that animal, it's going to reduce the prevalence more and more. There is other white breeds of cattle, such as Falanis, and in Australia we have a lot of tropical cattle called Brahmins, and they are white, but they just actually have almost like a black skin with white hair coming out of their skin, and they don't get eye cancers. Another European breed which doesn't get them is the Jersey cow, and you can see Jerseys, they come from islands off the United Kingdom. Very good milk producers, high butter, fat, and protein, but they do not get eye cancers. I don't think I ever saw a Jersey cow with an eye cancer, despite seeing hundreds and hundreds of Friesians in my time. So again, Jerseys are a very safe breed from the point of view of eye cancers. And your endemic local breeds, such as the Gur and Sahiwal, are very resistant as well. I'd be very surprised if anyone has actually seen an eye cancer in those breeds when they're pure. Okay, so we're going to talk about how the disease progresses in the different types of cancers. So I'll start with cancers of the eyeball, or globe cancers. And we can see in the first photo, there's a small plaque on the lateral limbic area. And we can see that it's quite a small lesion. And there's another one there. And they often begin as a smooth white plaque. They may progress to a papilloma, so they'll actually start lifting off the eye, and then they go into a malignant stage. So if you look at the next image, that's a Montbéliard cross, probably with a Frisian, and she's got a severe malignant eye cancer on the globe of her eye, we can see there. Okay, so third eyelid cancer is the most common. These lesions start as an ulcerative or hyperkeratotic lesion. And many of these will actually regress spontaneously. So they're quite hard to see, but if you have close contact with the animal, then you can notice that instead of having a smooth area of mucosa, you have a slightly lifted area there. These tumours can become quite large without invading the globe. So they can be quite spectacular, and they can still be quite easy to treat. And there's a more severe tumour, which has been going for some time. And then finally, we see in the third image what happens to the majority of these cancers. As the cancer tissue grows, it doesn't lay down a very effective blood supply, and then often the tumour itself will slough. So we'll go from an obvious lesion, like in the second image, to a lesion which you really can't see in that third image. So here's I'll show you sorry, I'll just go back a slide. You can see that image there. So we can see the massive amount of discharge, of mucopurulent discharge coming down the cheek. That's something to really look out for. And we can see that reddened third eyelid in the corner there. And we can see some ulceration of the cornea on the globe there as well. So they are the hidden eye cancer that definitely needs to be got onto quickly if we're going to treat it effectively. One way we can identify these is if we put a clean hand or a gloved hand, we can actually put our finger in around the third eyelid, and we can feel how thickened and hard the tissue is. And sometimes we can feel it occupies a large amount of the bony orbit is actually full of hard tissue. So they definitely need to be looked at. To a young veterinarian, they could think that's an infection, but it's just worth bearing in mind that it's extremely rare for them just to be an infection. So again, diagnosis is based upon breed primarily, and 90% of lesions that we see of anything affecting an eye is a squamous cell carcinoma in dairy cows or Frisian crosses. Some differentials that are very easy to tell from eye cancers would be pink eye. I'm sure you get a Moraxella bovis. Dr. Dixon, do you get pink eye in India? Not sure if you can hear me. Yes, but there's some pink eye lesions there.
No.
You don't?
Yep.
Okay, yeah. So it's a bacterial conjunctivitis spread from dust and flies, but a foreign body could cause a similar, obviously, a conjunctivitis in a cow. So we see a lot of that, but it doesn't look very much like a cancer. Obviously, you can have eye injuries from trauma, sticks and wires and things like that. And what we can see in this image here is a scar on a cornea from a lesion that's healed, probably a pink eye or a grass seed that's gone in and caused an ulcer. But we can see there's a lack of tear staining coming down from the medial canthus. So that tells us that that lesion is under control. This is a photo I took several years ago that was very spectacular. These cells obviously think they're trying to grow a hoof rather than conjunctiva. So a benign lesion. I think it was probably there for many years, but certainly very spectacular. Okay, so I'm going to talk about treatment now. And the first thing is restraint. I noticed in the photos that Dr. Dixon showed during the video that obviously the facilities aren't quite what we have in Australia. Maybe some of your cattle are better behaved than our cattle in Australia and more handled. But yeah, we certainly are blessed to have very solid crushers to hold cattle. But yeah, it really with sedation and good rope skills, you should be able to use whatever facilities are necessary. So as you can see in the photo, we use a strong halter, we use nose strips, and we use sedation. Very important for young vets if you're trying to obtain ropes that you get thick, non-stretch ropes, because any stretch in a rope will be exceeded by an animal as it thrashes, and it may appear tight, but it will quickly stretch when the animal starts to move. Obviously, tie the animal as tight as possible. And here I developed a, what we find in Australia is as we pull a head across to the side of a facility, the animal will move its head and then immediately swing its head back, and we'll lose the rope that we've got, and this can carry on for some time. So I found that if we come under the rope, like I've done there, and actually cut across the rope, we actually have a brake which we can operate with our right hand, while our left hand pulls the head closer, so we don't lose all of the rope that we get, or it basically allows us to control the animal as it comes closer to the side of the crush or even a post. The same technique can be used if you're pulling an animal up to a solid post. Okay, so sedation is certainly very important regardless of the facility to allow you to do the job effectively and quickly and cleanly. I'm sure that xylazine is the mainstay of sedation in cattle in India. There's two strengths in Australia. There's a 20 milligram and there's 100 milligram per mil. For this job and for most sedation rather than knockdowns, we would use the 20 milligram, the low strength xylazine. Our dosage is between 1 and 1.5 mils for a 500 kilo animal. And we usually put that in the coccygeal vein, but you could put it into the jugular vein if that was a problem. Very important when you're in a hurry and you're very busy to even set a timer and make sure that you actually do stop and leave the animal alone for 5 minutes, because the sedative will not work very well at all if you charge straight in and start pulling the animal around and upsetting her. Then she'll override the sedation and your job will be much, much harder. So yeah, walk away and have a chat to the farmer for 5 minutes and your job will be easier. Obviously, many alternatives exist. I don't know what is available in India, but nonetheless, xylazine is 99% of the sedation that we use in Australia. So I don't think it's necessary to talk much about that. Obviously, local anesthesia. Most of ours in Australia was 2% lignocaine. When I was in Ireland, there was lignocaine plus adrenaline. I don't know if that's available, but that would work just as well for this job. I think it works slightly faster. So if that's available, it will anaesthetize the tissue faster. One of the things I learned in my career was that if you are bad at putting in local anaesthetic, then animals despise you, and they really don't enjoy the local going in, and they fight, and they really will make life difficult. So really working on good technique with local is amazing. If you watch an experienced vet who's good with local versus a new graduate who hasn't been trained properly, you'll notice that the experienced vet will have the animal anaesthetized with the animal hardly aware that it's been used on it. So the mainstay of that technique is to just engage the first 2 or 3 mils off the needle through the skin, then slowly start injecting the local anaesthetic as you push the needle along. So you're almost advancing a bubble of local anaesthetic in front of the needle. And I find that it's amazing how well that's tolerated if you keep injecting as you slowly push the needle deeper into the tissue. Also, I was very big on using the minimum needle size that you can. Obviously, for a very small volume of local anaesthetic or sedation, you can use a smaller gauge of needle. For a larger volume, if you're putting in 100 mils of local, you may need a 19 or a 20. But for a small volume, it really is going to upset the animal and make life hard for everyone if you always reach for a 19 or a 16 gauge needle. So that's something to think about as well. So for the anaesthesia of the third eyelid, I've drawn this picture. I would start at the base of the third eyelid. Initially, I would actually squirt some local anaesthetic onto the actual tears and even shut the eye manually for 30 seconds, and that will anaesthetize the mucosa of the eye quite nicely. And it will mean that when you grip the edge of the third eyelid with the mosquito forceps, as you can see, the animal is much less likely to get to find that as painful and to start thrashing. Once you've done that, then obviously the technique I described, where we just advance the tip of the needle, and then we inject as we slowly push the needle deeper into the tissue. Okay, so for a third eyelid, I'd often use a 22 gauge needle, maybe even only 3/4 of an inch. A longer needle would be better, but you certainly can use that if that's the only 22 gauge needles that you have. And you can see in the picture, we're basically doing a ring block around the cancer. And we're making sure that our local covers that 10 mil margin, minimum margin of the cancer that we're going to cut out. The amount of local, sometimes I'd use 7 or 8 mils, 10, 15, it really varies with the size of the cancer, but you can't really hurt them with too much local. For anaesthetizing globe cancers on the eyeball itself, we often find that we have to prolapse the eyeball, actually remove the eyeball from the socket so that we can stop the eyeball retracting as we touch the eye with the cryotherapy probe. And so there did used to be...
tablets in that.
Sorry, is that a question? Sorry, is that a question?
No.
So, okay.
It's a disturbance. I muted the person.
Okay, sorry. Yes, so we did used to have a plastic device available in Australia that you could actually try and immobilize the eyeball with, but I couldn't find that for years. So I think that most cases people are actually prolapsing the eyeball like that. So again, sedation is really important. It'd be incredibly uncomfortable for the animal to do this without sedation. So 1 mil of, I put 20 mils, that should be 20 milligrams or 1 mil xylazine, as we discussed earlier. And then we actually need to infuse 20 mils above the eye and 20 mils below the eye. And what we're doing is we're anaesthetizing the rectus muscles behind the eye, the retrovolvar muscles. and that will allow those muscles to relax so that we can pop the eyeball out and then grip the eye when we actually freeze the eye. So to do the injection behind the eye, we need at least a 2-inch needle, 1922 gauge. We'll often bend that needle so that it doesn't tend to want to track towards the bony orbit. It tends to follow the contour. I've got a photo you'll see of that later on. Again, if it's done very carefully and we do inject as we push the needle in, I find that particularly with a 21 gauge needle, that because again, we need it to diffuse around and anesthetize those muscles. Okay, occasionally we find when we attempt this that the margins of the eyelid are too tight to actually pop the eyeball out. So what we do in that case is we put a little bit of local into the medial canthus, the eyelid skin around there, and we make a small incision just to basically open up that eyelid margin so that we've got a big enough hole so that we can pop that eyeball out. The popping out itself, I think you can see, we really are just sort of trying to peel the eyelid skin off the eye. And if we've got good anesthesia, the eye will pop out reasonably easily. And when we do have to make an incision, we'll obviously put a stitch or two in that medial canthus incision so that we clean it up nicely. Obviously, we've got an eye cancer on the eyelids themselves. We just infuse local under the cancer. Okay, so a bit more about cryotherapy. There is a gun that you can get where you pour liquid nitrogen into it. It has a trigger and you can actually spray the liquid nitrogen out of the nozzle. We have one in one of my practices, but for all of my career, we've basically used a probe instead. The probe could be made of any suitable piece of copper or brass with a handle so that it can be dipped into an AI can full of liquid nitrogen. So I had 3 different sizes. There was one that was about 15 mils, there was one that was 10, and there was one that was probably about 8 mils. And then we could actually swap the heads so that we could not freeze too much of the eye when we had a small cancer or a large cancer. So the other thing to do is, like we did for gripping the third eyelid with mosquito forceps, it's a good idea to instill some local anesthetic just into the tears, onto the surface of the eye, and then maybe shut the eye lids and hold them for 30 seconds, and that can just help reduce the discomfort for the animal when you actually start freezing the eye. And when you freeze, you can also shave. So it's often easiest to freeze the lesion first so that it's solid, and then take a scalpel blade in and literally just shave the cancer off so that you get better penetration of the tissue under the bulk of the cancer. And that technique isn't any good really for lesions greater than about 1 centimetre or 10 millimetres. If we try and do this for really advanced lesions, we find that it rarely works and they come back quite quickly. So I wouldn't use this technique if the tumour's bigger than about 10 millimetres. When we do the freeze, we do 3 30-second freeze thaw cycles. So we freeze, we then allow the eye, we drop the eyeball back into the socket, and then we'll wait 30 seconds, and then we'll cool down our probe, and then we'll repeat the process 3 times. And that should cause the cancer tissue to slough without causing too much damage to the underlying tissue. Again, I'm not sure what level of anti-inflammatories are available in India, but it would be a pretty painful situation for the animal to have its eyeball prolapsed repeatedly and have its eyeball frozen. So if you can use flunixin or ketoprofen injection after the procedure, or before you start, that's going to certainly reduce inflammation and the animal's going to be in less discomfort. Okay, so cancers on the eyelid skin. Again, these can be frozen, the same technique, but again, only small cancers. If they're too big and advanced, then we're probably wasting time to attempt to freeze them. If they're up to 15, we can excise them. But what we've got to be careful of is if we remove too large a section of eyelid skin, we basically change the conformation of the eyelid, and instead of when the animal blinks, it being like a windscreen wiper that effectively wipes the dust and debris from the eye, we'll end up with a dry eye that basically doesn't function well, that will become ulcerated and eventually need to be removed. So again, we can only cut out a small section of eyelid tissue if the animal's going to return to normal function in that eye. So there's an image of a cancer just with a diamond-shaped incision that we bring together. And again, we really do need to try and get the margins, ideally a 10 mil margin. If we get much less than that, then we do worry about recurrence. The final one to bear in mind is, again, this is probably a Montbéliard or certainly a Biafresian. And we can see that there's precancer and cancer surrounding the whole of the medial and ventral conjunctiva. So to attempt to freeze these lesions is a waste of time because the whole eye is just breeding cancer right through it. So in a case like that, it would be much more appropriate to consider removing the eye. Okay, so eye removal, obviously sedation is essential. For the local anesthesia, we do need a minimum 2-inch needle. And again, I don't tend to go for an 18 or a 16, I'd use a 19 or a 21. We're going to do the same anesthetic technique that we used for the globe prolapse in the eyeball. We're going to go dorsal and ventral, but we're also going to go lateral and medial. So they call it the compass block, and that would be if the left side of the screen is the medial side, that's where we would inject our local and try and get that local as far around the back of the eye as we possibly can. Again, I've talked again about trying to be very good at our local technique, because life is easy if the animal is not fighting us. So that's something to just work on. If you haven't done a lot of it, you'll find that it gets easier and easier if the animal's not in pain. With a 2-inch needle, we need the needle hub. The full needle needs to be deeply pressed into the conjunctiva to get the required depth. Some people would use spinal needles. We probably wouldn't because of the cost of them, but some veterinarians do get a cheap source of spinal needles that are 3 inches or 4 inches and use them as an alternative. After we've put local around the back of the eye, we inject a ring of local shallower around the conjunctiva and under the bony orbit. And then we do shallow local anesthetic. So we go just around the skin, only 1 centimetre or so deep, and that will cover the skin incision. So again, the volumes I put there, we make sure that we're not using more than probably 200 is our maximum dose. There is a theoretical toxic dose of local anesthetic. I've never got to it, but normally you'd find that you can remove an eye with 100 or 130 mils, most likely. Again, for an eye ablation, we definitely don't want to charge in. We want to give the anesthetic 10 minutes to take effect, or life is going to be very difficult for us. If we start the ablation and the animal is clearly feeling the surgery, then injecting more local anesthetic is a good idea. But asepsis has got to be very, very good for eyes. If we touch the skin or the ear or anything else, it's definitely going to potentially cause an infection. So I would re-glove or wash your hands and maybe metho them if you're going to inject local in with a syringe that's not sterile. And that's our volume. So the other thing I do sometimes is I'll actually bend the needle. So as I remove the needle from the needle cover, I'll actually try and contour the needle so it's curved. And as you can see in the picture, it tends to find its way around the back of the eye better rather than crashing into the bony orbit. which a straight needle is more inclined to do. So surgery for third eyelid cancer, this is quite a large cancer, but after a while you get used to the fact that this looks like if we grab it with forceps, it'll pull across really nicely. You just get the feeling for them in time. For removing them, we use curved scissors. You can use straight scissors or probably a scalpel blade, but I think curved scissors definitely make the job easier. And again, we need to grip and retract with forceps. Ideally, small mosquito forceps are very handy to pull the third eyelid across as we actually cut the tissue. Again, 15 to 20 mil margins we can often get with the third eyelid cancer. We can basically, within reason, remove as much tissue as we like, but we certainly don't want less than 10 mils. Again, if we pull the cancer out, we put the local in and we just feel like we're really not going to get anywhere close to a 10 millimeter margin, then it is worth reconsidering that it may be better to remove the eye in that case. And what we can also do, as I said earlier, is actually get our finger down into the medial eye and palpate. And if we feel that hard, thickened tissue, or we feel a lot of extra tissue in the eyeball, then again, it may be worth reconsidering what we're going to do with that cow. Finally, they very rarely get infected after surgery, but if you do have some cloxacillin eye ointment or something similar, then it doesn't hurt to put a little bit of that, a couple of mils into the eye afterwards. And again, if you have an anti-inflammatory, ideally give them an injection of an anti-inflammatory just to help with the pain the animal's in. And no penicillin or oxytetracycline or anything is needed. They don't seem to get infected. So that's what we do. Now, this is the analogy I've always used with clients in describing the margins with vet students. I always imagine that the tumour is my hand, and then my fingers are the tumour tissue, which may be invading deeper into normal tissue. So you can see that if we removed the cancer, which we've done completely in incision 1, we've chopped the fingers off, and those fingers are potentially neoplastic tissue that's going to reform on the cancer. So when we take a wider margin, we get the cancer plus any additional parts of the tumour that we can't see with the naked eye or feel with our eyes, feel with our hands. Okay, so eye ablation is a great option to cure ocular cancers. I think as a vet, we love things that we can fix. And when we have a cancer that we're confident we can remove the eye to cure, then I think we've done a good job. We found that we would get 95% success rate or more, where the cancer wouldn't come again, and it would be a quick operation. I've never lost an animal with an eye removal. And so I have heard of people using very long needles and doing eye blocks, like I think the Peterson eye block, and potentially putting the needle into the foramen and causing animals to sort of drop dead from the anaesthetic. But we certainly never lost a cow with an eye cancer. Complication rate, I would say, is about 10%, which is infection and wound breakdown. And I think the key is sedation, good local anaesthetic, and very firm restraint to make it quick and easy. If the animal's fighting you, if she's feeling the procedure or she's poorly restrained, then the whole thing turns out to be a circus rather than a veterinary procedure. Here's an animal we've removed the eye on. This is just showing the restraint, the importance of it. Blood loss is sometimes spectacular. So vet students are always a bit amazed at the amount of blood that's spraying all over the place. There's an image there. But although spectacular, and often the arteries will spray you in the eye and you'll end up with red vision, it rarely seems to be an issue as long as you don't muck around too much. So I think if your surgery time is 30 minutes or less, it's extremely unlikely that blood loss is ever an issue. And again, we never had an animal die of blood loss from an eye removal. Okay, so I thought about some practicals this evening. What does it cost? Well, we would charge probably 350, 400 Australian dollars to remove an eye, which I think is in the order of 20,000 rupees. So yeah, it's compared with the value of an animal to a farmer. It's a relatively small amount of money if that animal's cured and continues to produce milk for the family. And then time for a veterinarian, 1 to 1.5 hours. So that's the time on farm from diagnosis to leaving the farm. So again, it can be done in a good time frame as well. So a very effective piece of veterinary we can do. So the surgery itself, 22 scalpel blade, a large scalpel. We obviously clip and prep the animal for the surgery. And we'd often prep a large area, even sort of, if you can see my mouse, but around a lot of the face. You can see in the image below, you can see the amount of clipping. It's probably unnecessary, but if you do have clippers, you certainly can clip a lot of the animal and know that you've got a clean area to work in. Local anaesthetic, as we've described earlier. Initially, I start with a shallow incision, as you can see in the image below. And I basically try and mark out the margins for the incision, and you can see in the upper image. And when you actually clip the animal, there is actually large hair follicles that run around that dorsal, bony orbit, and they're a good landmark. And then on the bottom, we palpate the rim of the orbit. Probably better to remove not enough skin than too much skin. But in time, you start to realize what is the perfect amount of skin. If you don't remove enough, they get a large bulge in their eye from the blood clot. But if you do go too radical, then closing the eye can be difficult. It can always be done, but it will certainly cause you some stress trying to close it if you take too much eyelid skin. So for your first few, less is more, I would say. The next part, once we've done a very shallow incision, is to start dissecting the eye out. And I worked out in time that it's best to dissect the ventral lower lid first, so that you're basically, it means that blood is going to run down. And when you do the upper dissection deep on the dorsal aspect, you're not going to have those blood vessels spraying you in the face while you're trying to do the ventral part of the incision. So you start at the bottom and go very, very deep into the socket, and then work your way to the dorsal once you've gone very deep underneath. We've obviously got to dissect the skin off the medial and the lateral aspects of the wound as well. We just peel that back like we're removing a tumor or whatever else. So once we've got a deep dissection, we've dissected the skin from the medial and lateral aspects, the eyeball starting to come out nicely. We actually apply traction to the eyeball, to the whole lot, the skin of the eyelids and the eyeball, and that just helps us work out what tissue is remaining that needs to be transected with the scalpel. And eventually, when we get to the optic nerve, it's much easier to cut that when it's under tension. It's like trying to cut a hose pipe that's not under any tension. It moves around as you would try and cut it. Whereas if it's under tension, the scalpel is much more likely to cut through that easily. Some people use curved scissors for eye removals. I've never done that. I've always found that a scalpel, 22 scalpel on a handle, works really well. Occasionally, you'll even break a scalpel in there, but it's very easy normally to find the remaining part and then use another scalpel to finish the job. But you could try curved scissors once you get into the deep dissection. Some people prefer that. The other thing to bear in mind, particularly for third eyelid cancers, is as you go into the medial canthus where the cancer is, you need to really be careful that you go very, very close or on the periosteum so that you effectively don't leave any cancer tissue behind. So often I would do that part first, around the cancer so that I've really got the least amount of blood spraying around. And then I can make sure that I've really hugged the bone around the medial aspect. We sometimes even scrape the bone as well with a scalpel blade. I don't know how effective it is, but if the cancer is close to the bone of the medial canthus, then that's something we can do as well. Okay, so we would close with a continuous layer of a thick, non-absorbable suture. In Australia, it's called Supermud, and that just has to be very, very tight. We need a good bite of tissue, top and bottom, and we need to tension that incision the whole time. We really are, every suture we place, we're putting lots of traction on that suture so that we really try and produce a watertight seal, because the thing that stops the bleeding is entirely the fact that we've closed the wound. There's no other hemostasis that we do. So it really is important that we get a really nice tight suture line across the wound. So afterwards, we really want to clean the face up, dry it and spray it with an antiseptic or a fly repellent spray. If we leave blood all over the animal, it's going to be attracting lots of flies, which is not going to help the animal at all. And it's also going to upset the herd mates as well. So I think as vets, we should have the highest standards we can. So we would always take pride in having the animal leave the crush with a face looking beautiful. And that made us feel like we've done a good job. Very important to use long-acting antibiotics. I would imagine that there'd probably be a 90% rate of infection and catastrophic wound breakdown if we didn't. So we would use a long-acting oxytetracycline or a penicillin. Long-acting penicillin probably doesn't last as long as the oxytetracycline. The oxytetracycline we had would last for 4 or 5 days. So we would often do one injection of that, and then if there's any concern at all, we'd do a second dose 5 days later. If you only have a short-acting oxytetracycline or penicillin, a minimum of 5 days. And again, I think that if at all available, an anti-inflammatory would be a good idea for the animal. The other thing I always do is when I finish, I would remove the eyeball that often end up in a bucket of bloody water. I would always pull the eyeball out and actually dissect around the tumour and just try and work out how close the tumour went to the margins so that you have some idea of the prognosis. So yeah, I think that's an important thing, not to just chop it and drop it, but really examine it and try and think about your prognosis. So here's a photo. The upper photo shows an infected eye removal. We can see the dark red tissue in the middle is an infected blood clot. And I think these sutures have actually...
Hello, excuse me, sir. Hello?
Yes.
Sir, can we use BCG vaccine regarding for this treatment?
Sorry, can you say that again slowly, please?
Can we use BCG vaccine?
Can I use what, sorry?
Can we use BCG vaccine for this treatment, sir? One of the approach, as you said, cryotherapy and cryosurgery and excision. Can we use
yes.
BCG vaccine?
Sorry, can you use what injection?
BCG vaccine, sir, vaccine.
Oh, could you maybe type that to me? I'm not familiar with it. I might look at that question at the end. So if you could just use the chat box, we might look at that at the end. I'm not sort of understanding that question at the moment. So we'll come back to that at the end if that's all right. Okay, so in the first image, we can see that infected blood clot is sitting there. The second image shows the fact that we've cleaned the eye up. We've actually used a wound sprayer. This is just a pesticide or a herbicide pump spray full of chlorhexidine or iodine. And we've used that to hose deeply into the eye socket. And then we've often find that we actually have to get a clean gloved finger and then actually use that to remove the blood clot. Okay, so yes, I've got your question. BCG vaccine, okay, which is, I'm not familiar with it.
It is called Bacillus galmati gorin. Generally, we give for you know uh, for children, for human being.
Yes. Okay.
Control
Uh,
tuberculosis.
yeah. Look, I don't know. So what is that used for? Is that used for the treatment in India? Is it or?
No, he's asking that. I don't know. Dr. Sagar is asking. So you have any experience
Yeah.
of using BCG vaccine? I don't think so. Australia, you have that vaccine. It is very common in.
Yeah. Look, I don't know. I mean, it might be. I can have a look at that afterwards, and I'll talk to Dr. Dixon and see if we can come up with anything. But certainly, it's not something we've used in Australia. Yeah. Okay. So we'll get back to this. So yeah, this is about 10% of cases. Some of the time when you get an infection, you know that it's because you weren't clean enough. You have to be absolutely fastidiously clean when you do eye removals. So it could take an ear brush into your hand. Sometimes we'll even use an elastic band to tie the ear back away from the face, because any sort of touch from anything that's not sterile can cause an infection. So it can be just out of the blue. In Australia, when we've got warm, moist conditions, we get an increased rate of wound infections. I understand that India has warm, moist conditions most of the year, so that's going to make things a bit more challenging for you. But you will find that when it's very hot and wet, that's the worst time for doing these surgeries, but you don't have much choice about when you do them. The diagnosis side of it, where if they've got an infection, is pain. They'll often shake their head. They'll go off their feed. They'll become depressed. Their milk yield will decrease. You'll often see a swollen eye, even with watery pus or bloody water coming out from the sutures. Obviously, the discharge will smell terrible. You can get wound breakdowns, so the stitches are starting to break away from the skin, as we can see in this image here. And then the other thing is get your thermometer out, because it will cause a systemic fever if they've got a wound infection that's out of control. So if we get a wound infection, keep them on penicillin or Oxytet for probably up to 10 days after the surgery, if you can, because if you don't, the consequences are more severe. Checking the temperature will help you decide how long they need to stay on penicillin or oxytetracycline. This is a pink spray, we call it in Australia. It has a fly repellent and an antiseptic. So we want to try and reduce the amount of flies which are spreading additional infection into the wound. And then in this image here, I think we ended up actually removing a section of sutures, probably about a third of the wound, and then actually removing that blood clot, like I said earlier. So that will heal probably in 3 to 6 months' time. That will be completely healed, and the hair will have grown back, and you won't really know. It might have a small area without hair over the wound, but they do heal really well anyway. So it will look a lot nicer one day. Okay, wound dehiscence. Obviously, because we do a continuous suture, there is the danger of the suture being torn on a fence or on a stick. Again, we obviously need to re-stitch that, clean it very thoroughly and re-stitch it, and maybe consider using antibiotics for a bit longer if that's the case. Prognosis is basically 100% for cancer on the eyeball. But if we do remove an eye and feel a lot of cancer tissue in the eye socket, then obviously there's a high chance of the cancer returning quickly, and that can return within 2 to 4 weeks. And if there's concern about the margins, we may find that it returns in 3 to 12 months. We deal with it by selective breeding. So we need to be careful about the pigmentation around the eyes and about what breeds we're using, maybe considering Jersey blood rather than Frisian blood. And some of the red breeds of dairy cows can be resistant as well. So that's a good idea. And again, we want to avoid breeding from animals with lots of pink skin around the medial eye, like we discussed earlier. The biggest take-home message is treat early. In Australia, we have large herds, and we find that with herds of 300, 500 or 1,000, people just don't look at their animals, and a cancer that we could have treated really cheaply and quickly and effectively becomes a tumour that we can't even treat with eye removal, and the animal has to be sent to the abattoir or culled on farm. So really has to be treated early. I think in rural India, if someone has a phone and they can send a good clean photo to a veterinarian, then that's really going to help a plan to be made about the time frame that needs to be considered, and also that the correct treatment can be undertaken. So again, really important, because we leave a cancer, it will threaten the life of the cow, and it will result in poor welfare and economic loss to the client. So that's about all I've got. I think I'm close to time. So any other questions? That'd be great.